who is going to moderate this session for all of you. I have with me Dr. Giridhar, BH, the head of the Department of Pulmonary Medicine of Justice K. Segre Medical Academy with us, who will give us the introductory remarks. And the resource person for this webinar is Dr. Chirantan Bose. He is the Director for Patient Care Services and Precision Oncology at Data Cancer Genetics. So today's topic is on precision medicine and cancer therapy. And I have two very learned people with me to talk about this concept, and it would not be very nice on my part to say too many things, because I'm sure these two important people that we have with us today, they are going to give you a lot more information than what is known to some of us. So before we begin the session, let me have the pleasure of introducing our colleague at NIT University, Dr. Giridhar, BH. Dr. Giridhar is the head of the department, a professor and head of the department at the Department of Pulmonary Medicine at Justice K. Segre Medical Academy, the constituent medical college of NIT University. Dr. Giridhar obtained his MBBS from Rajiv Gandhi University of Health Sciences in 2004, followed by a diploma in allergy and asthma in 2007 from CMC Vellore and International Asthma Services, Colorado. And then he did his MD in pulmonary medicine from CSM Medical University in Lucknow, followed by his DNB in 2012 from National Board of Examinations, New Delhi, and then PDCC in June 2017 from Sanjay Gandhi Postgraduate Institute of Medical Sciences at Lucknow. And right now, Dr. Giridhar is taking care of the Department of Pulmonary Medicine along with his colleagues at the university. So he has a very exciting and illustrious career as a clinician and as a scientist. I must make a mention that Dr. Giridhar is also pursuing his PhD at the moment in the university. So from his time as a senior resident to young scientist, assistant professor, followed by associate professor, he joined NIT University as an assistant professor in 2011, and in 2019, August, he became the professor. He has over 20 publications. He has conducted several projects. Of course, the list is very long, so I will not take too much of time going through the list, but we have a very important clinician today with us to give us the introductory remarks about the topic of today's webinar on precision medicine. Over to you, Dr. Giridhar.
Thank you, Dr. Anirban, for elaborate introduction. And also, I thank the Consortium of Rare Genetic Disorders for providing me an opportunity to interact with all the eminent people on the panel today. So, when Dr. Anirban asked me to speak on this precision-based medicine, then two anecdotes came to my mind, so which are very important. The first one was in 2008 December. I was doing my residency at.
I'm sorry. Can you be a little louder? Thank you.
Hello? Thank you. We were doing residency in 2008 in King George Medical University in Lucknow. Then we diagnosed one case of lung cancer. The diagnosis came as non-small cell lung cancer, and patient had a pleural effusion by that time itself. So that essentially means it's a stage 4 disease. So at that time, diagnosing a lung cancer of stage 4 disease is like giving a death certificate to the patient in India, at least at that time. So we counseled the patient party, and they agreed for a chemotherapy. We started on gemcitabine plus cisplatin chemotherapy, that low dose regimen. And patient came back after a 21 days for the second chemo. By that time, all his hairs were fallen, and he was it was difficult to recognize him. And at that time, the Jeftinib was introduced in India as a third line chemotherapy, and uh, it was not the it was not the frontline recommendation, but yet uh, the consultant in charge of that patient decided to give the Jeftinib. And the patient took the Jeftinib, went home very happily, and he was relieved that the RDL of chemotherapy he need not have to go through. And patient came after months, maybe after 2 months, patient came back, and there was no effusion at all. We all were flabbergasted. We were really surprised what has happened. Then we felt that we have missed the diagnosis of pulmonary tuberculosis, and probably pulmonary tuberculosis was misdiagnosed as lung cancer, because till that time, whenever we saw any lung cancer patients, that too with the effusion, it was no point of return, uh, very clearly. But this was the one Jeftinib did the trick, and we were really surprised whether Jeftinib does that much difference. And then subsequently, we started giving Jeftinib, especially for adenocarcinoma. That time, the rule of thumb was non-smoker, Asian origin, and adenocarcinoma, and especially females. So you can give the Jeftinib straight away without any genetic studies. So we gave to many patients, and they did fantastically well. So the way we started seeing cancer completely changed after the introduction of Jeftinib, because we started seeing it as one more chronic non-infectious diseases like hypertension or a diabetes. So that really it was a such a big statement on me on lung cancer. I always remember this. So that was one thing. So after that, we started getting more and more interested about the tyrosine kinase inhibitors, these mutations, and all those things. We really understood as a clinicians how important are all these things. That made a very big statement on us. Secondly, now 3 weeks back, we had a one patient. It's a large pleural effusion again. We suspected a malignancy. Straight away went for a video assisted thoracoscopic pleural biopsy. Diagnosis came as non-small cell cancer, and patient was pouring liters of fluid from his chest cavity. Intercostal drainage was in situ, and he was almost every day 1 liter of fluid was coming. So when that much of fluid comes, the patient will lose a lot of protein. There will be a lot of catabolism. So we started on Jeftinib, but it did not act at all. There was no difference at all, because we started Jeftinib awaiting these molecular reports, thinking that we need not waste any time, because as patient was pouring out more than a liter of fluid every day. No response. Then EGFR mutations came. It was not sensitive. There was no sensitive mutations for the TKIs. Then KRAS mutations came. Again, it was not sensitive. And then there was a PDL1 mutation was there, and patient needed a drug addressed towards the PDL1. After that, patient yet to come back for the follow-up, where patient has received the first line of immunotherapy against the PDL1. So these two anecdotes very clearly shows that the role of precision medicine. There is the era of chemotherapy, generalized chemotherapy is completely gone. So we need to work up the patient to molecular level in each and every patient, and it is a patient-directed therapy, because it will vary from one person to other person. And as all of us know that the cancer is has a wide variations in the genomic markers. From one cancer to other cancer, it is different. Same cancer, one person to other person is different. So it's a very high time we move towards the precision medicine in the cancer therapy. We have already moved. Especially, we are very thankful to Dr. Anirban and his team. We are mapping so many patients, especially with the EGFR mutation, using a digital droplet PCR. Um, yeah, that's it. I want to stop there, and those two cases make a lot of statement. Then what can I narrate?
Thank you. Uh, can you please mute yourself? There's a bit of echo here. Yeah. Thanks a lot. I think that was a great way of putting it, a very simple way of, in a very simplistic manner, putting the entire concept of immunotherapy and TKI therapy. I think we have a lot of student participants today, as I understand, and I think they will understand this language, particularly if it is coming from a clinician. I think it makes a lot of difference how you put it. I think we all know about immunotherapy. We also, you made a mention about PDL1 inhibitor, that one you have mentioned, the second case. I think it's a nice way of making things simple for non-technical people or those who are non-clinicians out here. Thank you very much, Dr. Giridhar, for these opening remarks. I would like to now introduce our resource person today, who is going to take us through the topic today that he is going to present to us. Before I let Dr. Chirantan start his presentation, it's my duty to introduce our speaker. So Dr. Chirantan Bose is currently the director at Patient Care Services and Precision Oncology at Data Cancer Genetics. He is an MD pathology and has trained in hematopathology at Southern Medical University in China, followed by Karolinska University in Sweden, and for oncopathology at the University of Pittsburgh Medical Center, US. He also has a master's in clinical genetics from University of South Wales, UK, and is pursuing MBA from IIT Bombay. Oh, that I didn't know. Okay, great. Dr. Chirantan is an international fellow of the College of American Pathologists and also a senior auditor with the National Accreditation Board for Testing and Calibration Laboratories and for National Accreditation Board for Hospitals. So he's a strategist for medical diagnostic business initiatives and has played lead roles in the establishment and successful operation takeoff of several large-scale pathology labs in the country. He has published several internationally acclaimed manuscripts in reputed medical journals. Currently, as I mentioned, he is the lead in clinical operations at Data Cancer Genetics. He's also in charge of the Asia Pacific region, and his main area of work is in the area of precision oncology for providing evidence-based treatment recommendation in case of advanced cancers. So the story that Dr. Giridhar just narrated is something that make a lot of relevance for people like Dr. Chirantan, who give advice to clinicians on the mode of treatment. And in today's context, precision medicine is something which is a game changer in this field. So thank you, Dr. Chirantan, for agreeing to be part of this consortium. And thank you for taking your time out. We would be delighted to listen to you. Over to you. Can you unmute yourself, Dr. Chirantan? We are unable to hear you, Dr. Chirantan. I think there is a problem with your mic setting.
Dr. Anirban, I think, can you hear me now?
Yes, loud and clear. Thank you.
Okay. I will thank you for your kind introduction, and I'm happy to be part of this gathering, this session for sharing knowledge. And of course, we are always learning, and I think that should be the attitude and approach of all academicians, and especially the clinical people, because through learning comes better opportunities to serve and justify our work. And I think we should all take as much as learning with open arms. So I will now go ahead and share my presentation. Are we good to go?
Yes, Dr. Chirantan, please.
Okay. So, so today we will have a discussion on how we are having unprecedented and better outcomes in treatment of solid organ cancers by something that we call personalized cancer treatment. Now, this, in short, is a definition of precision oncology. Of course, precision is being used in today's times in surgical approach as well as in administering radiation therapy. So all that together combines to define precision oncology. But my discussion today is primarily around the medical interventions and outcome. So these are my disclaimers. Um, we can start with rather the pessimist's purview. And if you see in the last about 10 to 15 years, there have been large number of publications and studies which have denounced what we are trying to say today. We we have had the largely funded trials like Shiva, which have published their failure, and so many other publications which say to the extent of 90% failure in the outcome when you are using more of targeted approach through chemotherapy, immunotherapy, and other targeted drugs. This is quite contradictory to what we are trying to say today, or what is also well known in the cancer treatment community. Why is this so? Why is it that so many studies fail to show the benefit? And in that case, as the one of the publications which I always show is the last one that you see, which was in one of the Oxford journals, which says so much effort and so little progress. So quite a disheartening and pessimist approach at this point. But what exactly is the goal? Are we trying to showcase the success or failure of single agent molecules? Or we are trying to look at cancer treatment with a holistic approach? So that is where I think one of the key differences lies. And most of these studies which have shown their failures really have looked at single agents, have looked at single molecules. And that is one of the key factors which we as scientists need to look at. Are we looking? Cancer is a heterogeneous disease. It is an intelligent disease which rapidly changes its form. And and it is but quite obvious to note here that single agents are not likely to have that much of a success if we are up against something that is frequently changing. So, a candid start to the technical discussions. What do you figure out from this picture that you see on the screen? It is possibly a patch of green foliage with some dried material in between. That's more about it. And had this been an interactive session, I would have asked the audience to comment on what they feel the picture could be. But let me here show another part of the same picture. Here you see a bunch of people who are possibly nestled amongst some houses and looking amusedly. If this is part of the same picture, then we can assume that there is some kind of a mass gathering happening here. If I open up another part of the picture, you see another community of people who are staring, and then some people are sitting and they're looking. So some people may comment here that it may be a political gathering. Some people may say it's some other kind of mass gathering that is happening. But we really it's difficult to comment. Um, Another part of the picture, you see a person holding a post, and then there are some security personnel. So again, I don't know how much we can figure out from all these bits and patches. And if I show you the whole picture, now here there is a wild animal on the lower right corner of the screen. You can see a leopard being captured, and there are people. So then you know that okay, what's happening here is possibly a wild animal intrusion into a domestic area. This is very common in suburbs of most cities, especially Mumbai, where human civilization has encroached upon wilderness. But the idea behind this is that, are we really looking at a bigger picture? What is happening in cancer treatment, or what has been happening in the past 2 decades, is we have become microscopic in terms of the molecular genetic features, and may not really be looking at cancer as a whole, in the holistic. So this was the visual image which I wanted to request the audience to think of when we look at cancer, for its treatment and for its outcome. And this happens very frequently, almost in every case, when the clinician tends to focus. We see this, where when the cancer metastasizes to different organs, or when there is a second primary, there are at times different clinicians looking at the tumor of different organs differently. So it's a very heterogeneous approach as well. The need of the hour is to put together all the blocks so that we can justify the treatment and the outcome. This is another a, a graph, a histogram, which rather shows the grim success of tissue agnostic treatment versus targeted treatment, because most of these studies have focused on individual drugs for the outcome and not cancer as a whole. So univariate analysis does masquerade the benefits of what you could get as a whole. Um, um, now looking at what I say, I'm always optimistic. We deal with cancer, and but it's not just hollow optimism. When you see results like this, where you have a stage 4 ovarian cancer patient. On the left side, you see the radio contrast image of this rather young lady who had progressed on 3 consecutive lines of treatment when treated with a personalized regime of chemotherapy, in this case cyclophosphamide with etoposide and methotrexate. There is a progression-free survival and more or less almost a complete disease remission by about 1 year. So again, something which we would not really expect in conventional lines of treatment. You can see here, this is another late middle-aged lady who had buccal cancer infiltrating literally onto the entire cheek and the mandible. And you can see that practically within 2 months, just about over 2 months time, the response that the disease has had purely on medical treatment is quite amazing. And this was a patient who had failed on 3 lines of treatment. Here you see the drug combination. It is not just chemotherapy, it is chemo along with a targeted PIK3CA antagonist like everolimus. But the question is, what I am rather keeping as a suspense right now is, how do you derive this combination, that magic combination, which is likely to work the best. Another case of a 53-year-old breast cancer patient who had progressed on 10 lines of treatment, the standard of care treatment, so-called. And when administered this combination of chemo, that is temsirolimus with dasatinib, there was progression-free survival, and you can see the disease has enormously reduced in its extent. Again, in the tumor hallmarks, there are molecular genetic findings like the FGFR1 copy number change, which we see along with others. The point here is to not just confine yourself to one type of a molecular genetic finding, like a specific gene mutation or a specific large genetic aberration like a copy number variation, but to look at everything that could possibly go wrong or could be driving this disease. Another case of a triple negative breast cancer, which is often a grim situation for the treating oncologist, because a triple negative breast cancer is one that has practically no targeted treatment in terms of hormonal therapy or Herceptin. So it is ER, PR, HER2 negative and diffusely metastatic one. You can see that the disease has practically melted away within a month's time. So these are enormous impacts. And I know that people must be waiting for questions, but unfortunately, it's not a bidirectional interactive session. So I'm sure I'll have questions at the end of the session. Um, Now coming to kind of work that we are doing at the Tau Cancer Genetics, and something which is really changing the paradigm here. One of our recent publications was on the clinical utility of circulating tumor cells and how we can decipher chemosensitivity in vitro. So here what we do is that we isolate from blood samples, from peripheral blood samples, the circulating tumor cells, which now there is technology to identify such cells at a very high level of sensitivity from the blood sample, and then exposing these cells to an environment of a battery of chemotherapeutic drugs. Now this is where the magic begins. This is where we can have a whole range of chemo drugs, whether they are prescribed for that disease or not, to see how their response can be. And on in the histogram bar, where you see a lot of green and red lines, the green lines are practically those drugs against which there is cell death. There is visible cell death without culturing the tumor cells in vitro. These are the first line chemo cells which are isolated and then exposed to the chemo drugs. And the red lines indicate all those chemo drugs towards which there is inadequate cell death response. So what you can identify is the battery of cytotoxic chemo drugs which will respond in the given case. And there is no reason to believe, what we have gone ahead and shown is that there is no reason to believe that these are the same drugs which will not act in vivo. Of course, pharmacogenetic analysis is another background study that we do to propose which are the drugs that are going to have more than anticipated toxicity when given to the patient as well. So again, looking at the entire chemotherapy spectrum from a very broad perspective. Looking at the historical perspective of cancer treatment, I mean, it started practically, there is evidence of more than 5,000 years back when surgical amputation and cauterizations were done to organs or to limbs with such kind of florid malignant growth. And then about in the beginning of the last century, when we had radiation as a therapy to burn out the proliferative cells. Of course, radiation therapy has evolved much in the last 100 years. And then in the middle of the last century, when we discovered cytotoxic chemo drugs and how they could be given, and targeted therapy is more or less about less than 30 years old now. So it's a relatively very, very new science. And I will show you a little later how rapidly this one area, which is the green arrow, the targeted therapy area, is enhancing. Of course, about 10 years back, we had immune checkpoint inhibitors, and that's also grown significantly when we can unleash the body's immune response to act against the cancer. Of course, a very small percentage of population is sensitive to this kind of treatment. Most cancers do not respond to this, and it's a very expensive treatment line. So chemotherapy and targeted therapy is definitely an area that we would like to focus on. Of course, immune checkpoint inhibitors, because it's part of many cancer treatment recommendations now. We had some discussions on lung cancer, so I know that we have in the panel people who are from the pulmonary area, and I would like to talk more on that. But just to give you a highlight that, now that we are talking more on the molecular genetic findings, these are commonly called biomarkers, that is markers from the body which can be used to indicate or give an information of specific biological process. So we have diagnostic biomarkers which can be used to detect a disease. We have prognostic markers like HER2 expression in breast cancer, when we know that HER2 positive patients can behave relatively poorly, but now we also have therapies against HER2, that is Herceptin. So those markers which indicate therapeutic response are called predictive biomarkers. And then we have various biochemical markers which are surrogate markers, which can be used to evaluate the extent of the cancer in a non-invasive way or from blood samples. Of course, these surrogate markers are being heavily replaced with liquid biopsy mediated markers now. And then, of course, we have markers which indicate resistance. So this is kind of all the markers which are in the blue boxes. But again, what I intend to showcase here is that we need to put all these together. And in clinical practice, normally it's a habit to go for specific markers at specific stages, but that's not something which would be beneficial to the patient at all times. You really need to have a holistic approach. So that is where what I mean, you need to club all these markers together to establish the continuum of care and to ensure that final impact is on survivorship. It's not just finding one marker and saying whether this marker is positive or not, but it is really enhancing the survivorship of patients and ensuring that that what we are doing is effective treatment. So the pictures indicate next generation sequencing or DNA sequencing, histograms, cytogenetics, microarray, and then cell surface protein expression through immunohistochemistry. But what we are really showing the value of is of putting all this together. So a little bit more about the techniques here, because I know that there are scientists listening to this. So so a tumor sample normally can give us the following. It can give us the DNA, it can give us the RNA, and it can also give us the cells which have the proteins on their surface. So we can really look at DNA and RNA and proteins. Now, the conventional way to detect protein expression in clinical laboratories is to do immunohistochemistry and some amount of proteomics. So we get that data, we put that in a box, and simultaneously we also sequence now with the high throughput next generation sequencing. We can sequence DNA and RNA in a matter of hours and analyze the data in a matter of days. So we put together that in one box, that is the sequencing data. And when we put the protein and the sequencing data together, that is where we find out all the markers together, whether it is single nucleotide variations, whether it is insertion deletions, copy number changes, of course, microsatellite instability, tumor mutation burden, which are markers for immunotherapy. I will be giving you a snapshot later on, and the surface protein expression, and then putting all of this together. The mechanisms or the techniques in the background are digital droplet PCR, next generation sequencing, real-time PCR, FISH, cytogenetics, immunohistochemistry, live cell imaging, as I showed to you. But the effectiveness is only when we get all of this together and don't do it piecemeal. So these are, visual snapshots of some of the techniques I'm sure laboratory scientists have seen. And again, why is it important? Why are we talking of looking at everything together? Now, this is a New England Journal diagram, which is really useful in understanding this. If you look at the tube here, that is the tube where we've collected blood sample. As we all know that cellular components settle down, which is mostly the red blood cells. On top of that is a small grayish layer of white blood cells and nucleated cells where we get our circulating tumor cells also from. And then there is a supernatant layer of the plasma, which has got these broken fragments of DNA and also the exosomal RNA, which can be captured for next generation sequencing. So when you look at individual mutations through sequencing, that's where you are looking at a very, very nucleotide level. So basically, if you look at the green, the blue and the red, triangles, what it's indicating is that as we go down from whole genome sequencing to something like a digital droplet PCR, our focus on nucleotide defects is becoming far more precise. We can look at far more precise nucleotide defects. But when we are looking at whole genome or whole exome sequencing, we are looking at the genome as a whole. And in between, there are these various other mechanisms. when a particular gene is in its normal form, in its unmutated form, that is called the wild type, and whereas when it mutates, there are various different types of errors which are the genetic mutations. Now it's possible, why I'm showing this tube is that even if you don't have the tumor tissue, you have this the genetic material of the tumor, which is coming in every individual who has the tumor. These genetic components come in the bloodstream, and that is the identifying those is the liquid biopsy component. So again, we have multiple different mechanisms here. We have the tumor tissue block, we have the blood or the plasma sample, and then we are combining together the entire histology and the protein expression along with the DNA and RNA sequencing to come together with a comprehensive analysis. So it's again the continuum of all these, and you can use various different sample types in this. Lung cancer patients, you can get very good quality genetic material from their effusions, like Dr. Giridhar was saying just before. So again, different types of assays, different types of analytes, putting all of them together to assess, what the cancer means. This is more from a cancer understanding standpoint, because you have genetic defects which indicate hereditary predisposition. And then, of course, we know that when treatment is in question, it is predictive. Then you have circulating tumor fragments, and then even you can identify tumors of unknown origin by various molecular genetic signatures. Now coming to, I would like to bring your focus to some of the international recommendations and guidelines. College of American Pathologists gives a lot of guidelines which are used in day-to-day laboratory practice, and it has in its very recent 5 to 6 years guidelines has included various genetic panels of both DNA as well as transcriptomes and single gene mutations in the standard molecular approach which a laboratory can adopt for genetic evaluation. So these are just, what that cap is saying something. And now I would like to bring focus with an example of some of the lung cancer discussions so that it is more in perspective. Now, earlier times, non-small cell lung cancer, or for that matter, even the lung cancer as a whole, was considered to be one disease. But we realized, in the 1990s that the histologic subtypes of adenocarcinomas, squamous cell carcinomas, and other small cell carcinomas are three different broad entities, which is the histologic subtype. When we went into the molecular genetic signature, we saw that adenocarcinomas are in almost 50% cases much different than what is squamous cell carcinomas. And these all genes that you see, whether it is ALK, HER, BRAF, PIK3CA, EGFR, are define different driver signatures of the lung cancer. And I will show you how important these findings become from a treatment perspective. But the pie chart, which is one gray color in the beginning and multicolored in the end, just indicates the number of molecular signatures that have evolved in the last 10 to 15 years. And taking the example which was given in the introduction, you can see here that in around, this is more interesting for the scientists, because, in the EGFR inhibitors, which are very common in lung cancer treatment, if you see the beginning of this bar in 1997 was when there was preliminary investigation that EGFR is a targetable focus, and EGFR inhibitors can work in isolation. And within about a matter of 5-8 years time, EGFR inhibitors like geftinib and erlotinib were really launched in the market. And in a matter of about 10 years, that is from 97 to 2009, geftinib was shown to have better response in these mutated lung cancers and showing a better response. Now, if you see, ALK rearrangements were identified in non-small cell lung cancers in 2007, and we had crizotinib in the market in 2010. So practically within a matter of 3 years, you have a target identified and its drug. So that's how rapidly cancer treatment is changing now. And you have so many more, so many more examples now, immune checkpoint inhibitors, how rapidly within a matter of, again, 3 years, they have come into the market. And uh, and very recently, again, osimertinib, practically in 2015, the data started coming in that osimertinib is effective in a particular type of EGFR mutation, that is T790M. And now osimertinib has been recommended as first-line treatment in some of the lung cancers, and it is definitely superior to other EGFR antagonists. So how rapidly these changes are happening now, and you see the density more towards the right side of the bar, that within a matter of 2 to 3 years, and COVID is one of the examples that we are all looking at. Within a matter of less than a year, we have such a mass production of a vaccine, although the safety implications really need to be seen. But then that we have so many available options of vaccine already in the market is a huge scientific feat in itself, and we must not fail to recognize that. Um, Looking at some of the guidelines which are commonly used in clinical practice, we already have, in various types of non-small cell lung cancers, where NCCN recommends that we should do a broad spectrum molecular genetic testing and not just single gene mutation. So it's not any more testing only for EGFR or ALK or ROS, but doing the entire battery together. And because there are treatment options practically for everything, so we've seen how ALK and MET amplifications are effective for crizotinib, whereas the HER2 mutated tumors or the ERBB2 amplified tumors use various combinations of Herceptin or trastuzumab, in this case TDM1 or adutrastuzumab, which is effective. Then I will be talking about tumor mutation burden and immunotherapy also in a bit, but this is just to give you a snapshot that the recommended guidelines also are sort of overpopulating them. So there is no uh, setback in taking into consideration that a wholesome molecular genetic finding is going to be more effective. Anti-RK fusions are really one of the new mutations that we are talking of. We have more of the head and neck cancers which have high frequency of this mutation, and so also for breast cancers, both in adult as well as in females. And why this is because this is relatively new, 2 years old publication, and now we have the NTRK targeted drugs available in the market for these cancers. Even for lung cancer, now NTRK gene fusion should be done as a testing strategy, is what has been included in the recent guidelines for by NCCN. So I think we discussed a little bit about protein expression, about chemosensitivity, and about targeted drugs. Moving on to the category of immunotherapy drugs, you would have heard the name of Keytruda or pembrolizumab, which is now available even in the Indian market for various cancers. Microsatellite instability is again a protein expression defect which we evaluate. Classically, we used to do this in colon cancers, but now in many other solid organ tumors. And a microsatellite unstable tumor has got a higher response to immunotherapy. So it's not just the PD-L1 targeted marker, but it is other markers like microsatellite instability as well as tumor mutation burden. So tumor mutation burden can be evaluated both on the tumor tissue as well as on blood, and it indicates significant in these Kaplan-Meier curves. You will see that a higher tumor mutation burden shows a response to immunotherapy. So it's not just one marker. Again, immunotherapy is one drug, pembrolizumab or nivolumab, but the markers are three different. So you cannot even depend on one marker and say that, okay, tumor mutation burden is low, so we can't give. Maybe PDL1 is positive. Maybe microsatellite is instability is high. So you, again, for the same drug also, you have multiple markers to really consider, and that's a diagram of cancers against which such immune checkpoint inhibitors are effective. I wouldn't go into the biology of immune checkpoint inhibitors, but I think we all know much about how PDL1 and antibodies act on cancers, and this is just overlap of how microsatellite instability, tumor mutation burden, and PDL1 positivity overlap together and do not overlap in many cases. So those non-overlapping areas are where we really need to look at all the different markers, even to prescribe immunotherapy. Again, we know that tumor tissue availability is a question. In the real scenario, many times in oncopathology practice, we struggle to get adequate tumor content, and this is where I think liquid biopsy, what I showed earlier, comes into, and that has been again shown in the recommended guidelines. And this is where what I meant to say is that when you struggle with tumor content for genetic material, you do have abundant amount of genetic material in the blood plasma, which can be taken not just for initial diagnosis, but also for follow-up longitudinal monitoring of how these patients are going to be. That's the beauty of liquid biopsy, when we can isolate tumor genetic material from the blood. Again, we spoke a bit about DNA, a bit about RNA, is that many times the genetic mutations are really more florid and visible at the RNA level, at the transcriptome level, and not that much on the DNA or the cell surface protein level. And that's why, again, in this case, we identify bevacizumab, which is a VEGF antagonist, as a treatment option, because we see that the VEGF pathway is really overexpressed in this particular case. And this comes from either tumor RNA or exosomal RNA sequencing, when we look at the transcriptome profiling to find out, okay, you have a drug which is effective when at the transcriptome level. So again, all these hands, this is one of the snapshots we use to educate clinicians in our company, is that it is joining together all these hands of immunotherapy, cytotoxic chemotherapy, targeted therapy, other additional markers which may help to find out even non-anti-cancer drugs which may be effective in given cases. So putting all that together is what is multi-analyte process, and that is why now I recapitulate my first slide where I spoke of all those studies which were pessimistic studies which failed to show benefit. And here we have done and published the Resilient trial. This is available in public domain, where we showed an overall outcome benefit in over 90% cases when such a pan molecular genetic approach was adopted rather than single findings, and how many patients benefit out of this. So this study was published, and we had phenomenal survival benefit and remissions also in many cases. And this is one of the waterfall charts which is there in the study, where you see of so many solid tumors, there is disease remission, and on RECIST scoring, there is a reduction in disease burden when such wholesome approach are adopted for personalizing treatment rather than single agent treatment. So again, this is just a comparison of all those pessimistic studies, whether it is the NCI match, whether it is Moscato, whether it is the MD Anderson trial or the Shiva. We have shown far better overall disease response in our study as compared to this, just because we have, in our large cohort, evaluated and treated these patients with multitude of options and not single agent. So that's, I think, the difference between univariate and multivariate study, and that's what scientific minds should look at. A couple of our other publications which also look at encyclopedic tumor analysis and how it has been effective in neuro-oncology and even advanced brain tumors. So I will finish my talk by saying that a tumor biopsy and going for single marker testing, be it by NGS, is really the thing of the past. In the future, we are looking at a comprehensive assay with a drug screen and functional diagnosis, which will lead to treatment decisions. That's the future. Thank you, and I will stop sharing my screen now.
Thank you very much, Dr. Chirantan. That was excellent overview on the concept of precision medicine. And the take-home message would be this, for me, would be encyclopedic tumor analysis. I think this is something which we need to look into, as your data suggested, that it has to be this multi-platform tumor interaction. It's something similar to system biology that you talk about. You are talking about transcriptomics, you're talking about genomics, you're talking about data from the proteomics, and you all put together, and then you look at, you decide on a particular course of treatment for a patient. Now, we have a few questions for you, Dr. Chirantan, from the participants. I would like to read them out for you on behalf of them.
Sure.
So the one question that is interesting has come from a faculty in a pharmacy college, and the person has asked, can you please elaborate on how research related to the field of precision medicine can be practically conducted and the results applied for our patients in Indian scenario, not only in cancer but also to manage drug related issues?
No, I think very pertinent question here, and so these were the challenges, or this was the situation at even Datta Cancer Genetics. Although we work with oncologists globally, but then our data set came from Indian patients originally. And I think research institutes should have the active collaboration with clinical setups, because you cannot do, even to get the specimen of cancer patients, you need to have collaboration with a clinical center. So I think research on cancer biology, on molecular genetics of cancer, should begin with research institutes collaborating with clinical institutes, understanding what are the clinical needs. Because we answered at Datta Cancer Genetics, we answered a core question. A core question is, what does a clinician do when there is a failure from the standard of care treatment? So that was a core question which we started answering. So I think research institutes should also, in discussion with the clinical colleagues and the patients looking at the clinical scenario, identify what is that area that they want to answer. See, there is a lot of work which is still being done in transcriptomics, which is still being done on proteomics. So I think research institutes should actively collaborate, identify the areas of interest. Cancers are increasing in India, be it breast cancers, be it lung, head and neck cancers, which is one of the highest burden cancer in the country now. Once you collaborate with a treating physician, with a cancer center where patients come in, and then identify which is the area that you want to work. So I think that's the initial step which should happen. That clinical laboratory collaboration or clinical research collaboration is very essential, and I think that's where the Indian or the Asian system differs from what happens in the West, because in the West most of these researchers originate from clinical institutions. So here we don't have that much of an active research in the clinical institute, and that is where a research institute must collaborate with a clinical center and then originate their research. So that's the first step. And again, then you identify which are the cancers that you want to work. What is your area of interest? Is it single genes, or is it next gen sequencing with transcriptome? Once you identify that, once you gather a few tens to 100 data sets, you will yourself see the findings coming in, and then collaborations can be built with, you know with more functional biology, drug discovery development. There's a lot of drug discovery development process happening in some of the pharmaceutical companies within India as well. So those collaboration points can be explored at that stage. So begin with a clinical collaboration, identify what are your areas of interest in terms of the laboratory wet lab workflow, and then what kind of an output you want to draw, whether you want to look at treatment solutions or you want to look at prognostication, better classification, better diagnosis. I think there's a lot over there.
All right. So yes, that is a very valid point that you have mentioned. Dr. Chirantan, I have one more question for you. When you mentioned about this combination of different techniques and to look at all possible scenarios in terms of the molecular signature that a patient might have, and these examples that you gave, from a patient point of view, I mean, the economic burden on the patient would be massive. So how do you take care of that? Because I'm giving you one example of a single gene liquid biopsy test on a digital PCR platform itself is about 18 to 20,000 rupees, if I'm not mistaken. This is the cost that is being cost. So if you're going to bring in NGS, I think whatever the examples that you have given, multiple genes that have been identified to be deregulated or having mutations or certain variations in the copy number. So all of these you have to come together. And yes, doing research at one point, yes, we would think of coming up with a panel, and then we say that, okay, if the patient fits in this panel, maybe this is the choice of the treatment that you are going to give. But when you are practically speaking, if you have to put it in practice in a clinical setting, how difficult it is going to be for the hospitals, particularly for the patients, because in India, we don't have this mandatory insurance scheme that is something which is very, very different in the West. So how do you tackle that problem?
Again, very pertinent question, Dr. Anirban. Thank you for bringing that up. Before I answer to you that, we at Datar Cancer Genetics function in 100% clinical setting. We are not a primarily, we do our active research, but we are a clinical laboratory and we offer tests for patients, So, but I would take a step back, these were questions which definitely challenge us. And we did pertinent cost benefit analysis, because here we are impacting life, we are impacting longevity, we are impacting drug A versus drug B. So now when we do when we did this kind of cost benefit analysis, what we saw is that the elimination of ineffective drugs which might have been given to the patient had this kind of workup not been done, vis-a-vis the effective drug itself, is a major economic impact. Okay, say for example, if you are giving a targeted drug, even for kind of the newer generation EGFR tyrosine kinase inhibitors, which cost few thousand to ₹1,00,000 or more, for its course, but without the benefit, then what's the loss over there? So that's one. The other loss is of health and survival of the cancer patient itself, the productive life years ahead, and even now with the cost of sequencing, etc., coming down, this encyclopedic analysis is not very enormously undoable. We have hundreds of patients getting these tests done every week at our laboratory. The Asian subcontinent is using it. Most of the cancer centers which are of acclaim are using it for all their advanced cancer patients. So it's not, the benefit comes when you evaluate vis-a-vis giving a treatment where there is no known outcome. comparing it with something where you have that, in vitro, you have already seen that it is going to benefit, and then you see the benefits coming in the patient as well. So there is that benefit of avoiding or eliminating the ineffective drugs, which is number one. Number two is that uh, we do evaluate cases on a very personalized level, on a case to case basis, where we look at whether it is possible to break it down to possibly at a transcriptome level or at a more focused DNA level, and reducing the cost of testing there. So we do those kind of permutation combinations, and you absolutely have to do that when you're talking of personalization, because we want as many patients to benefit out of this as possible. Now, on the other side, I really, we actively talk to non-government organizations, to various consortiums where uh, some kind of a financial aid needs to be developed so that more patients can get this kind of diagnostic workup, because as you understand that this kind of testing requires a very high level of infrastructure, so obviously there has to be a cost analysis done. But I think more of funding support should now be built, because there is visible and tangible benefit that every cancer patient can get out of this. So I think more funding bodies should come forth and support, this. So I saw some question coming from Dr. Aarti, I think. Mute, I think, Anirban.
Dr. Aarti is asking, what kind of impact is this holistic molecular approach having on the overall survival of cancer patients? Some specific examples, if you can give.
Yeah, no, that's what I showed in the resilience study. We have this, single arm cohort of patients where we have seen overall outcome benefits in more than 90% patients in our cohort, okay, of diverse solid organ cancers. Relapse-free remissions of about half of them, and definitely progression-free survival of a very significant percentage. So these are different kind of outcome changes. Reduction in disease burden is a different outcome benefit. But when you're really looking at, say, pancreatic cancer patients or cholangiocarcinomas, the frontline oncology care team is really helpless in those cases. You don't have, it's very difficult to give treatment in the blind. You see the patient deteriorating practically on a day-to-day basis. So having identified treatment options, starting those treatments, and then of course following through the benefit is a huge paradigm shift. So I would say overall outcome benefits in over 90% cases.
All right. So thank you very much. I think we have a few more questions, but we have already crossed the time. That was very interesting and very engaging talk, Dr. Chirantan. First of all, I would like to thank you for giving this wonderful insight into the combination of precision and personalization. I think it's a mix of both, as I understand from your talk, and this encyclopedic tumor analysis that Datar is doing. And of course, as you rightly mentioned, it needs a bit of infrastructure. And if a hospital setup or a clinical setup has to embark on such kind of treatment strategies, I guess this basic level of infrastructure development is a must. Of course, we at NITE also, we would love to discuss more with you on this, and maybe we'll see if we can benefit from your experience and your knowledge on this, and if we can set up something like this in our university and in our clinical setup. Having said that, it's my formal vote of thanks for all of you. I have a host of people to thank now. First of all, I would like to thank you for taking your time out and being with us on a Saturday afternoon and enlightening us with the kind of work that you are doing at Datar and the examples that you have given are really, really encouraging for people working in this. I would like to also thank Dr. Giridhar, who has joined us today. I understand that he is busy. He was busy quite late till yesterday, but he said, since I have committed, I will take time out for this. So thank you, Dr. Giridhar, for being here and for being a part of this webinar. Also, thank Mrs. Sadhana Deshmukh, our Director of Curriculum Development, for Staff Development Center, sorry, for facilitating the conduct of this webinar, and also to Mr. Mahesh for helping us with the live transmission of this on YouTube. Thanks to Dr. Aarti and Dr. Bharti for support in the consortium activities. And finally, thanks to the management at NIT University for allowing us set up this consortium. I must mention here that the consortium was set up from a seed grant from the university, and we have started taking the baby steps, and I'm sure with people like Dr. Chirantan and others who are associated in the consortium, I think we're going to grow, and we're going to have a lot of activities in future in the consortium. So thank you once again. And finally, thanks to all the participants who have registered for this webinar. We have a question on YouTube, which has been put up by Mr. Sadhana. Okay, the question before we, I think we should not disappoint the participant who had asked the question. So Dr. Chirantan, very quickly, if you can give an answer to this. So, well, the question is to summarize. Of course, it may not be very quick, but I hope you'll. Okay, please summarize if there are any targeted therapy against cancer stem cell. If so, which type of cancer and which targets of cancer stem cells?
Okay, so this is a bit of off our discussion today, because the concept of tumor stem cells arises more for hematological malignancies when we are looking at the bone marrow, where we have a classification of the cell of origin versus the mature cells. Whereas what we discussed today was more on solid organ malignancies, where we have, so there are no pluripotent stem cells really where we are looking at a lung, or when we are looking at, all these mature organs. It is cells which, driven by the or pushed by the driver mutations, become florid, or there is some kind of a biology change at that stage. But irrespective of that, what we are talking of today is when you identify a target, a molecular target, which may be at a cell surface, at a protein level, or at a DNA or at a transcriptome level. If you have a drug which can go and hit on that target and inhibit it, then that mechanism which is leading to the florid multiplication will stop, or will be at least countered. So that is the mechanism of targeted therapy, where you have specific drugs which are working on specific molecular genetic mechanisms. So I would say that stem cell changes, although even in hematological malignancies, the florid abundance of the cells within the marrow or within the blood itself, demands drugs which will go and sit on those. So, like for example, in leukemias, in acute myeloid leukemias, we have targets which work on the FLT3 gene fusions of the malignancy. So and so on and so forth. In chronic myelogenous leukemia, we have drugs which affect the tyrosine kinase pathway and ultimately the BCR-ABL driver fusions, which lead to an increase in the number of blast cells in the marrow. But I think that is the distinction, and that is one of the reasons why Datar Genetics also per se has focused itself to find treatment solutions for solid organ malignancies, because the mechanisms in solid organ malignancies are slightly different from those that happen in the bone marrow or in hematological malignancies. So I think that's the difference, if I may.
All right, thank you very much. I think because of time constraints, we will have to stop here. It was a very engaging and very interesting presentation. Dr. Chirantan, we thank you once again, and thank you everyone for joining us. Before we sign out, the feedback form has been pinned on the description at the YouTube, and it is also there in the chat box. The student members and those who have registered to get your certificate, you have to fill up the feedback and send it to us. So on that note, thank you once again, everyone, and thanks for being part of this webinar. Have a wonderful weekend, and till the next time, we'll see you again with another webinar in this webinar series of the Consortium of Rare Genetic and Bone Marrow Disorders at